Good evening, everybody. We're glad that you are here. I'm Adejoke Ayola. I'm the Dean for the School of Health. And we're quite excited that you are in this room. So I'm just here to welcome you. And we're quite excited about our partnership with Michigan State University. And I will be introducing our liaison person from Michigan State University. And then he will be able to continue with this Your Health lecture series. So just to introduce Mark Brevey, he's the Director for Community and Government Relations at Michigan State University College of Human Medicine. And his work includes developing positive relationships with businesses, with schools, with community leaders, as well as universities, just to promote and encourage partnership. So that's one way I would summarize his work. And we've been working with Mark for so many years, and he graduated from Calvin. So I would love to celebrate that. And his work takes him around, here in Grand Rapids, Flint. He's working with so many other institutions. So we're quite glad, to have Mark Brevey here. Please welcome Mark.
Well, that's just such a nice introduction. We had some great time with some pre-health students earlier. We had a nice dinner over at the Prince Conference Center. I was able to remind everybody this is 13 academic years at least that we've been doing the Your Health lecture series here at Calvin. Calvin does have a very big spot in my heart. This facility, especially, my wife, the first time I saw her, she was welcoming students to chapel, and we actually got married right here as well too. So always such a pleasure to be back on campus. And now I have a nephew that's actually a sophomore here at Calvin. So I get back here as much as I possibly can. So thank you again, Dina Eula, for that great introduction. Again, my name is Mark Brevey. I'm Director of Community and Government Relations at Michigan State University College of Human Medicine. And again, we've been collaborating between the two institutions for at least the last 13 years as an extension of the Early Assurance Program. In addition to thanking Dina Eula, I also want to thank Dr. LaRue, who's the pre-health advisor here at Calvin. She's been helping us plan this event the last few years. I'm sure there's plenty of other people at Calvin that also help with this. I don't know all their names, but just want to thank Calvin for the great hospitality between the use of the facility and having us for dinner as well. I would like to note that at the conclusion of Dr. Hoogstra's presentation, he will answer questions from the audience and those written into the Q&A feature for those that are joining us virtually as long as time allows. With that, I would like to introduce our speaker. Dr. David Hoogstra is a pediatric hematologist oncologist at Corewell Health in Grand Rapids, where he also serves as the endowed director of the Hayworth Innovative Therapeutics Clinic at Helen DeVos Children's Hospital. David is an assistant professor at Michigan State University College of Human Medicine in the Department of Pediatrics and Human Development. He earned his bachelor's degree in economics and business, interesting, now being a physician, while also pursuing pre-med here at Calvin University, and received his MD from Wayne State University School of Medicine. He completed his residency in pediatric hematology oncology fellowship at Spectrum Health, which is now Corewell Health, and his work includes treating children with blood disorders and cancer. Dr. Hoogstra.
Good evening, everyone. Mark, thanks for that kind introduction. As was mentioned, my name is Dave Hoogstra, and I'm a pediatric oncologist and a Calvin graduate, but I'm also a Christian who had my faith shaped in large part here at Calvin. I met my amazing wife, Amy, sitting back there here at Calvin, who's also a Calvin graduate. My parents went to Calvin, And I now have two daughters who are 5 and 6 years old. And if I have anything to say about it, they will also be Calvin graduates in a few years. So I have been very blessed by Calvin College, and I believe strongly in the mission of this place. And so it's really an honor to be here with you all this evening. As a pediatric oncologist, I am constantly thinking about how to cure more children with cancer. It's sort of an obsession. For my whole life, I've loved trying to solve complex problems. And childhood cancer is one of the world's big problems that I'm devoting myself to trying to solve. And tonight, I'm thrilled to share with you all about the advances in treating one particular form of childhood cancer called acute lymphoblastic leukemia. Leukemia is the most common form of childhood cancer. And here we see data from the US National Cancer Institute showing the rates of childhood leukemia compared to other types of childhood cancer on the left. And on the right, we see a figure that shows that approximately 1 in 4 children diagnosed with cancer will be diagnosed with some form of leukemia. So this will be the topic for this evening. However, before we dive into a discussion about childhood leukemia, let's back up and set the stage by first talking a bit about cancer in general. At its most basic level, cancer is uncontrolled cell growth. Normal cells respond to growth signals and undergo regulated cell division, in which one cell becomes 2, becomes 4, and so on. And you can see that there on the left. A good example of how this works is if you get a cut on your skin. The skin's injured, that prompts growth signals to be secreted by surrounding cells. This stimulates the skin and other connective tissue to grow and multiply in order to heal the cut. And then when the cut is healed, those growth signals stop. Your skin cells stop multiplying and everything is well. In a patient with cancer, however, that growth becomes dysregulated and uncontrolled. This almost always happens when a normal cell develops genetic changes that cause it to become a cancer cell. And while we know that cumulative DNA damage from UV light, for example, can lead to skin cancer, cumulative DNA damage from smoking cigarettes can lead to lung cancer, for nearly all pediatric cancers, we really do not understand why genetic changes occur in normal childhood cells, causing them to become cancer cells. However, once that change from a normal cell to a cancer cell happens, then the uncontrolled growth takes off. And now cells are multiplying without any growth signal, and they continue to multiply. Depending on the type of cancer and its location, this leads to the development of tumors, which over time, if they become too large or too many, leads to normal parts of the body not being able to function. And then ultimately, in its most severe form, causes so much organ dysfunction that a patient can die. This is why we all think of cancer as such a great evil. Now, if we think about the magnitude of cancer's impact worldwide, the World Health Organization estimates that there are 20 million people diagnosed with cancer every year. And of those 20 million people diagnosed with cancer, an estimated 10 million people will die of cancer every year. To think about the reality of that a different way, that's roughly the number of people who live in the entire state of Michigan dying every year from cancer. And what that means is that roughly 1 out of every 6 deaths worldwide is attributed to cancer. Now, if we zoom in and think about the United States, thanks to our US healthcare system, infections and other things that cause many deaths around the world cause many fewer deaths here in the US. So now cancer jumps up to becoming the second leading cause of death, closely behind heart disease. And although cancer in children and adolescents is quite rare, it's still the leading cause of death from disease after infancy in the US. So as I mentioned earlier, this is a great evil worth fighting. And while all these statistics paint a pretty grim picture, the great news is that we are making significant progress in our treatment of cancer, with survival rates for all patients diagnosed with cancer improving from roughly 50% in 1975, now up to over 75% in 2020. And I'm excited to share with you all tonight the remarkable story of the treatment of childhood leukemia. Leukemia is a cancer of white blood cells. And so in order to understand leukemia a bit better, let's talk about how white blood cells and other healthy blood cells are created normally. For all of you aspiring pre-health students in the room, this is a theme of medicine that you'll see repeated over and over throughout your training. We need to understand how the body works normally to understand how disease causes the body to function abnormally. So here we see that blood is actually produced by bone marrow inside our bones. And what bone marrow consists of are the cells called hematopoietic stem cells. These are really remarkable cells that continue to multiply our entire life. So here you see 3 cells. Those 3 become 6, become 12 and 24 and so on. And as they multiply, they develop into the mature blood cells that you see there on the right. So the mature blood cells are red blood cells, white blood cells, and platelets. Each of them have a specific job or function. The red blood cells, their job is to deliver oxygen. Most of the body needs oxygen to function. And so the red blood cells come over into the lungs, big breath in, air comes into the lungs, oxygen in the air is grabbed a hold of by those red blood cells. They go back to the heart, out to the rest of the body and deliver that oxygen. That process repeats. That's the job of the red blood cell. The white blood cells, that's our immune system. Those are infection fighting cells. And there you can see depicted a few different types of white blood cells that all have different roles in keeping us healthy. So a dramatic oversimplification of the immune system would be that the white blood cells are specifically designed to identify what cells and things in our body are supposed to be there, what are normal cells, and what's not supposed to be there, or what might be causing illness, and identify those and eradicate them. The last are the platelets. So those are small, sticky cells that stop bleeding. If there's a hole in a blood vessel, those platelets have a way of sensing it, and they go and they plug up that hole. Then proteins circulating in the blood called clotting factors, those can detect that there's a plug of platelets, and they go and they sort of seal the hole. So if you think of rebuilding a wall, platelets are kind of like the bricks, and those clotting factors are the mortar. I often describe this to patients and families, and every time I'm struck by just how miraculous the body is. And it often makes me think, like the psalmist says, I praise you, for I am fearfully and wonderfully made. And here I want to take a little diversion to take a moment to thank Dr. John Ubels. So Professor Ubels was my physiology professor when I was here at Calvin, back when it was Calvin College. And it was that physiology class, learning about how the body works, seeing glimpses of the Creator, that I really fell in love with medicine. Understanding how the body is supposed to work when healthy is, as I mentioned, a foundational aspect of medicine. And it was John Ubels who really ignited that passion for how the human body works. And it was Socrates who said that wisdom begins in wonder. For me, it was the wonder of physiology that has led to my career in medicine. For the students in the room tonight, you are being given an immense opportunity to learn from truly amazing professors about so many fascinating disciplines. So ask yourself, what is it that really makes you wonder? So now back to leukemia. If a white blood cell becomes a cancer cell, then the form of cancer that develops is called leukemia. And leukemia is then further classified based on whether it is acute or chronic, with chronic leukemia being very rare in children and acute leukemia being much more common. Then there's a further categorization based off the type of white blood cell, either a myeloid cell or a lymphoid cell, leading to either acute myelogenous leukemia or acute lymphoblastic leukemia. And then if that doesn't seem complicated enough, just as there are both T and B lymphocytes in the normal immune system, there can be B and T lymphoblastic leukemia. The most common of all of these types of leukemia in children is B cell acute lymphoblastic leukemia, which is what I'll spend the rest of our time talking about this evening. So how is leukemia first identified in a child? The typical symptoms of leukemia, symptoms being things that might be noticed by a child's parent, are the child looking pale, or maybe being fatigued, fevers, infections, bruising, bleeding, or limping or bone pain. These are all things that a parent might identify. Signs of leukemia are things that as a physician I might identify through an examination of the patient or with laboratory tests, include fever again, anemia or low red blood cells, thrombocytopenia or low platelets, either a low or a high white blood cell count, an enlarged liver or spleen, enlarged lymph nodes, and sometimes actually seeing leukemia cells in the blood when the blood is spread out on a microscope slide. So then how is leukemia actually diagnosed? Leukemia is diagnosed by finding those leukemia cells in the bone marrow. As we talked about, the bone marrow is normally the place where healthy blood is made, but it's also the location where leukemia cells are identified if present. So if I have a suspicion that a patient might have leukemia, they will have what's called a bone marrow biopsy and aspirate. That is a procedure where a needle is put into the bone marrow, usually in the hips, while the patient is sedated. Once in the bone marrow, a few teaspoons of bone marrow, which look like blood, is removed and sent to the lab for analysis. There, a variety of tests are performed. Tissue pathology means that they take the bone marrow, put it on a microscope slide, and look under the microscope to identify the abnormal appearing leukemia cells. And here's a picture of what leukemia looks like under the microscope. So it's a little small, but you can see the sort of more faint pinkish looking cells. Those are red blood cells. Even smaller, there's little kind of bluish purple dots. Those are platelets. And then what stands out are all the leukemia cells. So in the bone marrow, there would normally be healthy developing blood cells, but here you can see it's just overrun by these abnormally growing and dividing leukemia cells. In addition to tissue pathology, they also do what's called cytogenetics in the lab. Here they take the leukemia cells from the bone marrow and they actually put them in a petri dish. In the petri dish, they grow and multiply, and then ultimately in the lab, they extract the DNA out of the leukemia cells to look for those genetic changes that may have led to the development of leukemia. And then lastly, and probably most importantly, over 1 million bone marrow cells, think about that, 1 million bone marrow cells are run individually through a machine called a flow cytometer. I won't go into all the details of how flow cytometry works, but this is truly remarkable technology that looks at a variety of proteins on the surface of a cell and can identify, based off those surface proteins, if the cell is a normal bone marrow cell or a leukemia cell. And this is really the gold standard for deciding if a patient does or does not have leukemia. Lastly, leukemia cells can also make their way into the cerebrospinal fluid, or CSF, in and around the brain. And so a lumbar puncture is performed to take a sample of cerebrospinal fluid for analysis to see if there's leukemic involvement there as well. So now let's move on to the treatment of leukemia. And for that, let's take a quick look back at the history of cancer and cancer treatment. Some of the stories that I'm going to share now come from the book, The Emperor of All Maladies, which many of you may have heard of. Although pretty dense, this is a fascinating description about the history of cancer treatment. So if anyone in the room is really interested in learning more about the history of cancer treatment, I'd highly recommend this book. In the book, one of the first recorded descriptions of cancer comes from the ancient Egyptian physician Imhotep, who described bulging masses that are cool, hard, and dense. As an oncologist who examines patients with tumors that are cool, hard, and dense, I find the descriptions of ancient physicians to be fascinating in how accurate they are and how they still hold true today. And in his notes for these masses under a section titled Therapy, Imhotep wrote a simple, ominous sentence: there is none. Later in ancient Greece, the historian Herodotus described the story of Atossa, the queen of Persia. He describes Atossa surviving after a painful breast tumor was cut out. And many think that this may be the first account of the surgical resection of cancer, which remains a pillar of treatment for many forms of cancer today. And then from the time of ancient Greece all the way until 1896, there were no other medicines or treatments that showed any benefit for the treatment of cancer. Can you imagine that? All those years with no improvement. It was then in 1896 that a medical student at the University of Chicago named Emil Grube is believed to have been the first person to use X-rays to treat cancer, thus ushering in the use of radiation therapy for cancer. So we see that at the start of the 1900s, there were really two approaches to cancer therapy: surgery and radiation. But what to do about leukemia, a cancer where there's nothing to cut out and there's no specific tumor to radiate? Here we come to the story of Sidney Farber. Sidney Farber was a physician in Boston in the late 1940s. Before the late 1940s, a diagnosis of acute lymphoblastic leukemia in a child was a death sentence. The disease was universally fatal with an average survival of just a few months. Doctors often viewed leukemia as an insurmountable foe, and there really was no effective treatment. The medical community as a whole was largely pessimistic about the process of curing the disease with medicine, as surgery and radiation, as we talked about, had been the only known effective treatments for cancer. But then came Sidney Farber. Farber was a pathologist at Boston Children's Hospital. As a pathologist, Farber was not the type of physician who treated patients, but more of a scientist who spent his days in the hospital basement, examining the tissues and organs of children who had died from various diseases, including leukemia. He was deeply moved by the tragic and predictable course of childhood leukemia and began to wonder, there's that wonder, if a disease like leukemia that was a systemic problem might require a systemic solution, a medical solution. Farber's hypothesis was based on a curious observation. He knew that bone marrow cells, which, as we reviewed, are the major site of normal blood production, required folic acid or vitamin B9 to proliferate. He also knew that leukemia cells, which grow uncontrollably, also relied on folic acid. Now, the prevailing belief at that time was that giving folic acid to leukemia patients might help them. Farber, however, had a different, counterintuitive idea. What if you blocked folic acid instead? He thought that if he could find a drug that acted as a folic acid blocker, it might starve the rapidly dividing leukemia cells without causing too much harm to the normal, slower dividing healthy blood cells. So Farber reached out to chemists at Laterly Labs, a pharmaceutical company, and managed to obtain a new and really unproven folic acid blocker called aminopterin. It was a potent drug, and he had no idea what the right dose of the drug would be. But in the winter of 1947, he began a clinical trial with 16 children who were in the terminal stages of acute lymphoblastic leukemia. The trial was high stakes, almost desperate. Farber administered the drug as an injection, and the side effects were severe. The children developed mouth sores, hair loss, and bleeding. The drug, which was highly toxic, attacked their healthy cells. But then something remarkable happened. In 10 out of the 16 children, the leukemia seemed to go away. Their bone marrow, which had been choked with these cancer cells, began producing healthy blood again. Their fevers dropped, their spleens shrank, and they started to regain their energy. The children who had been on the brink of death were, at least for a brief time, cured of this terrible disease. Farber's findings, published in 1948 in probably the most famous medical journal in the world called the New England Journal of Medicine, were met with both excitement and skepticism. Many doctors were just unwilling to believe that a drug could have such a dramatic effect on cancer. Some even criticized him for his controversial and, at that time, pretty radical approach. But the story of aminopterin has laid the critical foundation for modern chemotherapy. And while the remissions were only temporary, and all of the children that he treated eventually died of their leukemia, the trial proved two really important things. One, cancer could be treated with drugs. This was a paradigm-shifting idea that moved the focus from local therapies like surgery and radiation to systemic ones. And two, remission was possible. For the first time, a period of disease-free life was achieved for leukemia patients, proving that the disease, while not yet curable, was also not invincible. What I love about the aminopterin story is that it's not just a story about science. It showcases the courage of Sidney Farber to try something new in the face of immense suffering and what seemed an overwhelming challenge. It showcases the bravery of young patients and their families and the dawn of a whole new era in the war on cancer. And it paved the way for the future development of more effective and less toxic chemotherapies, ultimately leading to the high cure rates for childhood leukemia that we see today. So it was really Sidney Farber who helped establish chemotherapy as the third pillar of cancer treatment. So we have now surgery, radiation therapy, and chemotherapy. And I find the story of Sidney Farber so inspiring that it's a reminder to me to never doubt that one person with a vision for a better future and the courage to act can change the world. I'm going to say that again. Never doubt that one person with a vision for a better future and the courage to act can change the world. And although the use of aminopterin, later to be called methotrexate, showed that medicines could effectively treat leukemia, with the use of aminopterin alone, no patients were ultimately cured. What this graph shows, however, is how that initial breakthrough with aminopterin was built upon over the next 80 years. This graph is what we call a Kaplan-Meier curve, and it's used frequently in the field of oncology to show how effective various forms of cancer therapy are. On the y-axis, you see the percentage of patients surviving, and on the x-axis, you see the time since diagnosis. So if you start on the far left side, at diagnosis, all patients are alive. But over time, as their disease progresses or returns and patients die, you see the percentage of surviving patients drop. And that's how those curves drop down. This graph shows the survival of patients enrolled on Children's Oncology Group clinical trials from 1968 to the early 2000s. So let me explain briefly what the Children's Oncology Group is. That is an international collaboration of now more than 200 children's hospitals that all work together to improve the treatment of childhood cancer. So in the 1940s, no children diagnosed with leukemia survived. However, in the late 1960s and early 1970s, a few children started to be cured. And it's the use of these additional medicines, vincristine, prednisone, asparaginase, and their combined use, this multi-agent approach, that's what led to that. Now, each of these drugs have their own fascinating stories, which I won't go into detail, but I'll highlight that vincristine is extracted from the periwinkle plant, which I think is just such a unique way where the Lord has created plants that in their own way can help bring about redemption in children with leukemia. Another is asparaginase, which was actually discovered when the serum of guinea pigs was put on lymphoma tumors in a mouse and they shrank dramatically. Who thought to put the serum of guinea pigs on a tumor in a mouse? I don't know, but we've benefited dramatically from that. Another dramatic increase in survival was achieved later in the 1970s with the introduction of central nervous system directed chemotherapy. So if you remember, I mentioned earlier that it's now standard practice when diagnosing a patient with leukemia to check their cerebrospinal fluid to see if there are leukemia cells there. This is because of the experience in the 1960s where patients with leukemia that had received that multi-agent chemotherapy with vincristine, prednisone, and asparaginase, they didn't have their leukemia return in the blood or bone marrow, but they would have their disease return in the cerebrospinal fluid. What was ultimately discovered is that the CSF is what we now refer to as a sanctuary site. This means that leukemia cells can enter the CSF when a patient is initially found to have leukemia, but then because of the blood-brain barrier, the chemotherapy given by mouth or IV doesn't reach sufficient concentrations in the CSF to kill the leukemia cells there. And so it was that after we began giving methotrexate directly into the CSF, that the leukemia cells present there began to be effectively treated, and the frequency of having leukemia return in the CSF decreased dramatically. Since that time, additional efforts to risk stratify patients to tailor more or less aggressive therapy with what's a so-called reinduction therapy has also dramatically improved the outcomes for children with leukemia. Looking at this graph and realizing the collaborative effort of hundreds of pediatric oncologists over many decades with many thousands of children and families enrolling on clinical trials astounds me. If you ever question whether science is good and can improve people's lives, I want you to think about this remarkable accomplishment. So now we're ready to talk about the current treatment for children with leukemia. For patients with standard risk B-cell acute lymphoblastic leukemia, and for the sake of this talk, I'm not going to discuss therapy for other forms of leukemia. Therapy starts with 1 month of what's called induction therapy. Here, the goal is to induce a remission, meaning that the goal at the end of that first month of therapy is that there would be no detectable leukemia in the bone marrow of that patient. This induction phase consists of 3 drugs. You guessed them, vincristine, prednisone, asparaginase, the same drugs identified back in the 1960s. At the same time, however, patients are given methotrexate into their CSF to treat any leukemia that's there. Then patients have 1 month of consolidation, 2 months of interim maintenance therapy, 1 or 2 months of delayed intensification, and 2 months of interim maintenance too. All of these more intensive phases total approximately 8 months and require weekly appointments with me in the office where they are receiving IV chemotherapy. Then maintenance therapy begins, which lasts for 1.5 years and consists of daily oral chemotherapy, but only monthly appointments with me, again in the office. So in total, therapy for childhood leukemia extends for more than 2 years. As we've seen in the last slide, over time, the standard of care changes and new therapies have come along that have improved the outcomes of patients. But how does this happen? To better understand this process, let's talk about a new medication called blinatumomab. Blinatumomab is a bispecific antibody. What does that mean? Well, antibodies are proteins that have the unique ability to bind to very specific targets. What a bispecific antibody is a protein that has been specially designed to bind to not just one target, but 2. Here you see that blinatumomab binds to both CD3 and CD19. Well, okay, what does that have to do with leukemia? Well, CD19 is a protein that's on the surface of B-cell leukemia cells, and CD3 is on the surface of healthy immune cells. So by binding to both a leukemia cell and a healthy immune cell at the same time, blinatumomab activates that immune cell to destroy the leukemia cell. Activated immune cells, specifically cytotoxic T cells, secrete a substance called granzyme, which punches holes in the surface of the cancer cells, ultimately leading to their death. So in this way, blinatumomab harnesses a patient's own immune system to better find and destroy their leukemia. How cool is that? Like most new cancer medicines, blinatumomab was first given to patients with relapsed leukemia or leukemia that had come back after initial treatment. These are called phase 1 and phase 2 trials, in which the safety and early efficacy of a drug is explored. In these first patients who received blinatumomab, the results were striking. Not only was it very safe, but it also seemed to be a really effective medicine against leukemia. And once a medicine like blinatumomab has been identified that seems to have real potential for improving outcomes for patients, it then is tested in a large number of newly diagnosed patients to definitively determine if all patients with leukemia should receive this drug. This is called a phase 3 trial. The phase 3 trial that investigated the use of blinatumomab for pediatric leukemia was conducted by the Children's Oncology Group and was called AALL 1731. Sounds like a good clinical trial name. This trial was what is called a randomized controlled trial, which is pretty universally considered to be the strongest way to prove if a new drug is beneficial. In a randomized controlled trial, patients are divided evenly between 2 treatment groups, with each treatment group receiving the same exact therapy in all ways except for the group that receives the experimental drug, in this case, blinatumomab. So here you see that in this trial, both groups of patients received the same chemotherapy: induction, consolidation, interim maintenance 1, delayed intensification, interim maintenance 2, and maintenance, except one group also received 2 months of blinatumomab therapy. This is a trial that I enrolled many patients on, as did many of my partners at Helen DeVos Children's Hospital. So many patients in West Michigan participated in this trial in either the control arm or the blinatumomab arm. I just want that to sink in a second. Think about if you or someone you love was diagnosed with cancer. Then think about if there was an available clinical trial that was offered, a randomized trial in which you're not guaranteed a particular course of treatment. You might be excited about the potential of the new drug being studied, but also nervous about the possibility that it might not work, or worse, if it could actually cause more serious or life-threatening side effects. And just when you start to think, maybe you would want to try that new drug, you realize that even if you say yes to the clinical trial, you might be assigned to the control group. And then what if your risk of having cancer return is higher because you're not getting the new drug? These are all thoughts that swirl in the mind of patients and families as they think about participation on a clinical trial. And when I think about all of the parents that thoughtfully weighed this decision and then decided to enroll their children in this clinical trial, I'm struck by the gravity and the courage of all of it. The results of this trial were truly transformational, and the landmark report was published earlier this year in the New England Journal of Medicine. So let's take a look at these results. Here again, we have a Kaplan-Meier curve showing that in patients who received blinatumomab, 10% fewer patients had their leukemia come back. Having 10% more patients cured with the addition of a single medication is nearly unheard of in oncology. I'll always remember the day sitting in my kitchen at home when I saw the email that shared these remarkable trial results. When I learned that with blinatumomab, 10 fewer children out of every 100 diagnosed with B-cell leukemia will have to hear that their leukemia has come back. Praise God for that. So now in these final few minutes, I hope to leave you with inspiration and a challenge. So first for the inspiration. And for that, let's look together at some additional drugs currently being developed that may improve the treatment of childhood leukemia even further. In addition to blinatumomab, two other innovative therapies that are actively being tested for the treatment of childhood leukemia is an antibody-drug conjugate called inotuzumab ozogamicin, a mouthful, and chimeric antigen receptor T cells. So let's start with inotuzumab. It's a little small, but inotuzumab is on the lower left of that figure that we see on the screen. Inotuzumab is what's called an antibody-drug conjugate. And what that means is that inotuzumab brings very powerful chemotherapy directly and specifically to cancer cells. As we talked about before, antibodies are proteins that bind to very specific targets. In the case of blinatumomab, the target on the leukemia cell was CD19. Well, thankfully, there is another protein target on the surface of leukemia cells, this time called CD22, which you can see maybe ever so slightly the orange on the blue leukemia cell there. What is really cool about antibody-drug conjugates like inotuzumab is that once it binds to the leukemia cell, it's internalized inside the cell and releases the chemotherapy that's attached. I like to think of this like a Trojan horse. And in early studies, we've seen that inotuzumab may be one of the most effective single medications for treating leukemia. Next up are chimeric antigen receptor T cells, or CAR T cells. The way CAR T cells work is like this. First, a patient has their own T cells, which are one of those white blood cells I talked about, collected by a machine connected to an IV. Then those cells are taken to a lab where they're engineered to specifically seek and destroy leukemia cells. Then they're shipped back to the hospital and infused back into a patient. CAR T cells are a type of treatment called cellular therapy, since what's actually infused into the patient is cells and not a drug. And what's so cool about cellular therapies like CAR T cells is that you can think of them as a living drug. Once infused into a patient, these cells can remain in their body for the rest of that patient's life, constantly on the lookout for any leukemia cells that might reemerge. These are both treatments that we give to patients right here at Helen DeVos Children's Hospital, and they are so exciting because they are both so much more targeted than other forms of traditional chemotherapy. As a result, these medicines cause far less nausea and hair loss than traditional chemotherapy, and it's because of these targeted agents, like blinatumomab, like inotuzumab, like CAR T cells, that I can envision a future where children with leukemia are cured without any of the challenging side effects that so many children with leukemia still have to endure today. And now for the challenge. Tonight, we've thought about some big topics: the global burden of leukemia, the promise of an even better future for the treatment of cancer with more targeted therapies. So to close our time together tonight, I want to take a moment to reflect on vocation. I think an important question that we all ask at different times in our life is this one. What should I do with my life? What work do I want to pour my whole self passionately into? And as you think about that question, I want to share with you all this quote from Frederick Buechner that I hope many of you have already heard in your time here at Calvin. This is a quote that I first heard when I was a student here. It was impactful for me then, and it has continued to be impactful to me since I left Calvin. Buechner says that the place God calls you to is the place where your deep gladness and the world's deep hunger meet. And while deep gladness is not exactly how I would describe my work, for me, I know that using my God-given talents and abilities to care for children and families going through a battle with cancer does bring me deep satisfaction. So, what are your God-given talents and abilities? What are you really good at? And what is a great challenge in this world that you want to try to fix? And while we're here at Calvin University tonight, and while these sorts of questions are questions that students in the room are often thinking about, I know we also have a number of retirees listening to this lecture in person and online tonight. And I would challenge you all with the same questions. For many of you, retirement may offer you precious years with fewer distractions where you can make a huge impact in God's kingdom. So for all of us tonight, where is the place where your deep gladness and the world's deep hunger meet? And if the great challenges of this world seem daunting, ask yourself these questions, which I was first asked by my mentor, Jim Fonner, and that I'll now leave you all with today. If not you, who? And if not now, when? So thanks for your attention. I'd be happy to answer any questions. And while it's true, I am happy to answer any questions. Before we do that, we have a really special guest with us today. So Mateo over here is a patient of mine who was treated for leukemia, and he and his family wanted to be here today to share with you all a little bit of what their experience was like. So come on up, guys, and check. So when we talked about this, we said, well, let's just wing it. So that's kind of what we're going to do. So I guess, why don't we start? Well, Mateo, do you want to say hi to everybody? No? Okay. All right. Why don't you guys just start by describing from your perspective what it was like to go through a cancer journey with Mateo?
So my name is Edwin, Mateo's father. This is my wife, Sheila. I guess the biggest thing it was hard. It wasn't easy. Obviously we were young parents, so we still are young parents. But it's kind of a shocker to find out. But Hal DeVos did do a good job. I guess not a good job, but an amazing job, and truly made everything a lot easier. They kept us really well informed. And I mean, Mateo had a great time. I mean, even though he was going through hard times, I mean, I can't imagine going through what he did. But I mean, we're so grateful for what you guys did for us.
Thanks. So one question I wonder if you could share is, what were some of the hardest aspects of the journey? And then what were maybe some of the surprises, the bright spots along the way?
So I'd say the hardest things were seeing him really tired. He lost his hair pretty quick. I think that was kind of the more of a, what's a good way to put it? You could tell that he was a sick kid. But what made us feel a lot better was that he still smiled. As he went through treatment, he got a lot better. He started being more like a toddler should be, playing, running around. Because he stopped doing that when he first got diagnosed. He wasn't walking. He was crying every time he would try to walk. I mean, he learned to walk pretty quick, but as soon as he got sick, he would tell us that his legs hurt, and he was just not his normal self. But I mean, as treatment went by, he got a lot more happy. I mean, he opened up to you,
It, it took a little while, but we did get there. I'm wondering if you could describe the end of his therapy and what that end of therapy celebration that we have, because I know that was a big day for your family. He is. Oh, awesome. So describe for us a little bit about what happens when patients complete chemotherapy and what it was like for Mateo.
A lot of the nurses, doctors, the whole team was there that helped him throughout his treatment. Even some of the nurses that when he got admitted into the hospital, they really made it a really great experience and kind of a great milestone that he was going through. But when you guys did a little party, there was a whole sign, and he truly enjoyed it. And it was a really memorable moment seeing him ring the bell and kind of know that he's done with treatment.
Awesome. Well, thank you all for being here today. Anything else you want to share with the group? Well, thanks again. And maybe we could cheer for Mateo.
Questions?
Hey, Dr. Hoogstra, awesome talk, fabulous topic. Just some quick questions. So, what aspect of this leukemia do you think can be hard to diagnose in the patient? Like, what can make it hard to diagnose to say, oh, this patient has leukemia?
That's a great question. Leukemia can be tricky because a lot of the symptoms that I put up there are what I would say are what we call constitutional symptoms in medicine. They're, being tired, looking pale. These are things that might describe the majority of college freshmen. I don't know. It's they are symptoms that are not really specific. And so sometimes knowing when, to be concerned without labs, that can be a little bit more challenging. And then there are other situations. A good example is if someone has if someone has infectious mononucleosis, they can have suppressed levels of their blood cells, platelets, red blood cells, and white blood cells. And so patients with mono may also have fever. Patients with mono may also have enlarged lymph nodes, big liver and spleen. So teasing out when is this an infection and when is this leukemia can be tricky, but with med school residency fellowship, you all too can diagnose leukemia. Yeah, good question.
Oh, online.
Thank you so much. I was wondering what have been some personal challenges for you, or maybe challenges with the trials that you have had to overcome in your work.
So one of the questions related to that I was asked before this talk tonight was, how do you deal with patient suffering, working with with children who are very sick and may die on a daily basis? And the honest answer that I gave was, I don't know. I don't know if that's something that I'll be able to do for a 30 or 40-year career. I think that I am suited for the work, but there is an emotional toll that comes from this type of work. And so when you ask, what are some of the challenges? I painted an optimistic and hopeful story because I think there is reason to be optimistic and hopeful. But the sad reality is we are not successful with all of the patients that we treat. If you look at childhood cancer altogether, about 8 out of 10 children are cured, which is remarkable given the history that I went through tonight, but it's still completely unacceptable. It means that 2 out of 10 children are dying of their disease. So those are really the hard days. And then you asked about clinical trials. I also, in my role at the Children's Hospital, I run a lot of our early phase clinical trials. And I highlighted the success stories, but the reality of medicine and of early phase clinical trials is that we try and we try and we try, and oftentimes we are not succeeding in finding better treatments. And so those failed attempts at improving the outcome for patients, those are really challenging too.
Thank you so much. No, everyone keeps saying that, but yeah. What does a day in your life look like? Like, what is your routine? How does your week look? How do your weeks vary? That kind of thing.
It's a great question. As a physician, I think it's a little bit different for me compared to many physicians who spend the majority of their time seeing patients. I mentioned that I do quite a bit of research work. So about 2 days a week, I'm in the office seeing patients. It's about 7:30 to 5:30. And then the other days of the week, I'm meeting with my research teams. I run a lab, so I have a team of people in the lab that I meet with, and we work on our, what I call basic science research projects. And then I have a team of folks that run clinical trials, and I meet with them. And then there are a variety of other meetings, grant writing, paper writing that I do throughout the week. So it's a mix. It's a mix of caring for patients and doing research work. I also like to say, I mentioned my wife and my daughters. So when you ask what's a typical week, I drop my daughters off at school 3 days a week. I pick them up from school 1 day a week. And so as a physician, being engaged and a very present father is another priority of mine that I try to make happen.
Could you elaborate on some limitations of blinatumomab?
Yes, nice work with that word with blinatumomab too. So blinatumomab is given as a continuous IV infusion for 28 straight days. So you can imagine having a young, energetic patient that has their port accessed with infusion running for 28 straight days while they're at home. We've seen all sorts of surprises with that. I was mentioning that earlier tonight, actually. There was a patient who leaned over a campfire and the fire singed his IV tubing. We've had a young woman who had a pet rabbit, and while she was asleep, this is the story, the rabbit chewed through her tubing and she needed a new set of IV tubing and blinatumomab bag. And then she went home, and 2 days later, the rabbit did the same thing. So we said, okay, we got to do something different with this rabbit here. But there are logistical issues associated with administering blinatumomab. And then getting back to what I said about understanding normal body functioning helps you understand how things break down. The target for blinatumomab, CD19, is present on the surface of leukemia cells, but it's also present on normal B cells. And so just like blinatumomab very effectively destroys leukemia cells, it also binds to and eradicates B cells. And our B cells have a lot of important functions, one of which is making something called immunoglobulins. And so patients who get blinatumomab are at increased risk of encapsulated bacterial infections that cause sinus disease, coughs, colds. And so sometimes they need a replacement with something called intravenous immunoglobulin to kind of boost those levels up.
We have a question online from Catherine. What are common complications of ALL, and did the trial show any decreases in those complications with the use of blinatumomab?
So there are a lot of side effects of leukemia therapy. And there were many days that I would sit down with Mateo's family and go over each medication and all of the potential side effects. And those are difficult conversations. Chemotherapy can cause really significant side effects. Now, thankfully, the most severe side effects are quite rare, but they do happen. And so the list is honestly probably too long to go through, but it's one of the many reasons that we have so much more work to do. I showed that we are curing many, many more children with leukemia, and that is an accomplishment worth celebrating, but we have not declared victory. The current therapy is long with many, many side effects. And so my hope is that in the next 5, 15, 30 years, that we are able to achieve the same or better cure rates with much, much less toxic therapy.
I think we have time for one more.
You guys said there's a lot of side effects associated with the current treatments. How do you guys go about trying to find new ways or additional things you put alongside those to minimize those side effects or maybe improve the treatment?
So, great question, kind of a twofold answer. So one is, of course, looking to use medicines that just have less side effects. So some of these more targeted therapies that we mentioned, but when we can't do that, then we look at what we call supportive care medications. So one of the side effects of chemotherapy that we have a pretty robust arsenal to combat is nausea. So there are many medicines that I have at my disposal to help treat nausea if a patient's having that side effect. There's another medicine called leucovorin that helps prevent the side effects from methotrexate that occur in the normal cells, but uniquely doesn't protect the leukemia cells. So there are some examples of medicines that we have to blunt or minimize the side effects of chemotherapy, but there are also quite a few where we don't have great answers. Mouse sores, long-term bone weakening, low blood counts. These are things that we don't have great solutions to. So it's a work in progress. And I hope, seeing all of you here today, that in the future, you all, some of you maybe, will be interested in joining in this effort to try to improve the care going forward.
All right. Thank you all for coming out this evening. I want to thank our hosts, Calvin University, our co-sponsor, Michigan State University College of Human Medicine. Thank you, Dina Eula and Dr. LaRue. There she is. We look forward to coming back next year if you'll have us. Let's thank Dr. Hoogstra one more time and Mateo's family.